So thank you very much for joining this month's Innovation Month panel event on AI and innovating in healthcare to explore what role artificial intelligence and point-of-care testing technologies could have in addressing the problem of equity of access to healthcare in regional and remote locations, and also what the workforce implications are. Before we begin, in the spirit of reconciliation, I'd like to acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. And I'm based here in the beautiful warm Larrakia country in Darwin. My name is Maja van Bruggen and I'm the Director of Sustainability Action in the Northern Territory Department of Health and one of the co-leads of the Digital Professions Innovation Community of Practice, which is supported by the Australian Public Service Commission. So this event is part of Innovation Month, and because the Digital Professions platform is only accessible within the public sector, we've partnered with the Australasian College of Health Service Managers, or ACHSM, to make this available publicly. So given that this event is part of Innovation Month, the chat will be open for the next few minutes to allow you to post your name, role, organisation and location, or whatever you wish. During the presentations, however, the chat will be closed and the Q&A will be opened for you to submit questions. Once the presentations are finished, we'll work through the questions and in the spirit of a learning community, the chat will be reopened so you can share information and insights and connect with each other in parallel to the panellists responding to the questions from the Q&A. So, before I hand you over to our panellists, the current context for this session. So we're facing inequitable access to health services for people in regional and remote locations, healthcare workforce shortages, often harsh environmental conditions impacting on people and technology infrastructure, highly complex and increasingly complex healthcare needs, particularly within our Aboriginal communities, and all of these factors are being exacerbated by the impacts of climate change. We do, however, have many of the ingredients to address these problems. We just need to work collaboratively on how to combine these ingredients quickly and adaptively. So to expand on this, I have great pleasure in introducing you to the panel. Strap yourselves in. So our first speaker will be Dr. John Lambert. He's the Chief Clinical Information Officer of NT Health and past inaugural Chief Clinical Information Officer of New South Wales. He's an experienced intensive care specialist who's also worked in community practice. He's an experienced electronics hardware designer and software developer, has worked on service and solution design based in human factors, cognitive science and human-centred design, and is skilled in health informatics and ICT. Professor Brian Abbey is an NHMRC Leadership Fellow within the School of Computing, Engineering and Mathematical Sciences at La Trobe University. He's a co-founder of AllSense, a company dedicated to advancing nanotechnology-based cancer diagnostics. He holds postgraduate degrees in physics, nanotechnology and engineering and has a PhD in chemistry. He's been leading the development of new optical technologies for medical imaging and received a number of awards for research excellence and innovation, including for his co-invention of a rapid optical diagnostic test for early stage breast cancer. And last but by no means least, Professor Sandeep Reddy is an AI and healthcare researcher based at the Queensland University of Technology and chair of the Centre for Advancement of Translational AI in Medicine. He's authored several books and numerous articles about the use of AI in medicine, and is currently engaged in research on the safety, quality and explainability of the application of AI in healthcare delivery, and is developing AI models to treat and manage chronic diseases. He's set up local and international forums to promote the use of AI in healthcare and sits on various international committees focusing on AI in healthcare. Thank you to all three of you for taking the time to share your knowledge and thinking with us today. Over to you, Dr. Lambert.
Thank you, Maja. I'll just set up my share to begin with, just while I'm talking to you, make sure it all works. And reverse that silly thing that Teams does in minimising all my videos when I do that. Thank you all for coming. It's amazing to see so many interested in this topic. We've just hit over 100 attendees in the last few seconds, so that's pretty cool. Now, can you believe it? Just as we were getting together on this session, Maja related a story about a lawyer and their understanding of AI, which was, I won't quote the story, but it was pretty sad how little that person knew. And it was decided in that moment about 15 minutes ago that I was going to have to give a summary of what AI was. And I've never tried doing it in 10 minutes, but I'll do my best. Luckily, I have a bit of a slide pack because I get asked this question a fair bit. You've got my QR code there on screen as well. You'll get it at the end of the talk. If you want to use it to get my contact details, by all means do so. And I'm very happy to share this pack. I'm not going to be for those who have sharp eyes, there's 20 slides in the pack. I will not be presenting them all, so there'll be slide numbers that are skipped, and that's on purpose. Just as a high-level overview, like one of the things you've got to think about when you're when you're deciding to use AI, and I always emphasize this, what problem are you trying to solve? And we'll talk a little bit about that on the panel section. And then a lot of people ask, what type of AI? I'll spend a bit of time showing you the two main groupings of those, which is predictive versus generative AI, to give you some idea of what those two things mean. I won't be going into a lot of detail about the features of successful models, but we can do that on another day if you feel like it. But I will go into a couple of things you should be thinking about if you're going to buy a predictive AI solution or generative AI solution, or going to use one that somebody else is providing you. A reminder that, it's the humans that are still the most critical element of a human-computer interface, and you forget them at your peril. Some ideas of things we might want to think about using in our disadvantaged communities, or even the less disadvantaged communities, and a quick slide on some success factors and risks and pitfalls. And some of them I'll be going through really quite quickly. Just so that people understand, AI is actually quite an old technology. The theory and mathematics behind AI is started in the 1950s, so 70 years ago. Took a long time before we managed to build some solutions that are based on machine learning. Another 35 years before we were able to do what's happened since 2015. And looking at that, the real critical moment for AI happened only 9 years ago, which was when this annual competition that they had to train computers to recognize images. So there was a whole bunch of photos of things like apples, cats, dogs, whatever. And in 2015 was the first time that a computer actually was able to do a better job than humans at identifying a large data set of images. And then things have just accelerated since then. Now, this slide I actually used in 2020, only 4 years ago. And you could argue it's already obsolete, but it's not actually obsolete. These are some of the applications that we use predictive AI for. So, look at this image, predict what is the most likely feature on that image, or diagnosis if it was a CT scan. The second thing we often do is take a free text bit of writing from a clinician, a nurse, a doctor, an allied health practitioner, and break it up into an actual medical order. And then the other one is, and this is quite interesting, especially in remote areas, take this bit of information about a patient and tell us what's the likelihood that they're going to deteriorate, so that we can transfer them to higher level care before they deteriorate rather than afterwards. So it is still relevant. And I think the visual recognition predictive AI models are particularly relevant, because even though the Gen AI tools, ChatGPT, etc., that you've heard about, can look at images and understand them, they don't do it nearly as well or precisely in a healthcare setting as the predictive AI models. So this is a list of seven things I created when I worked for an AI company. Why would you use it? Like, what's the point of using AI? And the thing about AI is, how accurate it is. Humans are human. We don't know. If I have 6 registrars working for me, they'll all be operating at different levels of accuracy. And, a lot of people say, oh, I don't know about AI, it's a black box. Well, how do you understand how anybody's brain works? I have no idea. So the beauty about an AI solution is you might not know exactly how it works, but you know what its producible results are. And if you apply it to 1,000 records, you'll know every time you do that, it'll predict these things with this degree of accuracy and make this many mistakes, which you can't say about humans. It always takes about the same amount of time to do what it does. We like that to be seconds or minutes, but even if it takes 20 minutes, it always takes 20 minutes. Whereas clinicians operate on different timeframes depending on the time of day of week, and all the rest of it, as an example. The predictions that predictive AI makes are grouped really clearly. So one of our problems is coding, for instance. So, humans don't like picking things off pick lists. And if you ask them to code, they often do a pretty average job. But predictive AI machines will say, they'll be designed to say, these are the 5 things I will predict. And it'll always predict those 5 things. It'll never predict anything but those 5 things. So it's really useful for some solutions to have that confidence. Generally speaking, you can build AI systems that, look at every X-ray, whereas humans tend to miss one, or forget to look at a piece of paper, or forget to look at that one patient's record. Another feature of them is that they can look at data that humans can't recognize. So I can build an AI solution based on an infrared analyzer, or an ultraviolet analyzer, or a temperature sensor in one of Mary Claire's storerooms, which you can't sense as a human with enough accuracy to make any predictions about whether the air conditioner is going to fail, but an AI solution can. You like how I wove that in, Mary Claire? Explainability. Ironically, despite the fact that people complain about AI solutions being unexplainable, I've had personal experience of an AI solution that was looking at embryos in IVF, and the AI machine was able to show us that there were things happening in little videos of embryos that were predicting whether that embryo would result in a pregnancy or not, that the embryologists who've been doing this for decades had never noticed. But the AI was able to point out the features that actually were correlated with a success or a failure in an IVF pregnancy. And then the other thing is they can scale. And this is great. Like, it means we could theoretically produce a solution that operates across the planet. And that's one of the lovely things about ChatGPT. Anybody can use it. But one thing I didn't put on this is a list about why you use predictive AI. It's not a list of why you shouldn't. And one of the issues that's not on this list is accessibility. And accessibility takes many forms. Do you have an internet connection? Do you have a device? Does the AI model speak your language? Does it understand your cultural differences? Does it understand your disabilities, your linguistic differences? So in my office, we focus a lot on accessibility and call type issues, and that's not on this list. So you do have to think about that, because you might have a solution that you love the fact that it does all these 7 things, but if it's not accessible to a person, it might as well not exist. So the thing to know about generative AI, so this slide looks almost the same. That's the predictive AI slide. Hopefully it's updated by now for you all. This is the generative AI slide. And the thing is, it actually loses some of the benefits of predictive AI. So I make this point so that people don't forget the boring old predictive AI solutions, because this is more like a human, really. It makes mistakes. It needs a hell of a lot more computing and power and cost and money and heat generation. It's environmentally very unsound, generative AI. And if anything, it's the opposite of systematic. If I can put in the same set of parameters into a Gen AI model, and I can guarantee you the result will be different each time I put it in. And that can be great. It also can be problematic. So you've got to think about that. It's the completeness of coverage is currently still pretty generic. It's either got to be text, images, or audios, although that is changing rapidly. And like, the input scope is just amazing. That's why generative AI is amazing. Like, 100 lifetimes, I couldn't ingest as much information as these models have already ingested, and they're getting bigger and bigger all the time. It is truly mind-boggling, the amount of information that has been used to train these generative AI models, and that's probably really where their amazing power comes from. We don't fully understand how they work in some respects, and that's the other problem. They're less explainable than predictive models. And yeah, they're still pretty scalable, and they're, in a sense, they're actually more accessible, because, as you're probably aware, just about anybody can type something into ChatGPT, whereas getting a piece of software integrated with your EMR isn't quite as easy. So look, I'm not going to go into this in a lot of detail because I'm already up against the time limit, I think. But there are a whole number of steps to using and creating and implementing predictive AI solutions well. And of those steps, the end user, you, the people who might be using it, the people that aren't necessarily building it, you need to care about 6 of the 8 steps in creating a successful predictive AI model and implementing a successful AI model. I'm not going to go into the detail. That's for another talk. And in generative AI, what's really interesting is that you don't Well, sorry, these four items still matter, but then there's a whole lot of new issues you've got to care about. Privacy, data security, the way the prompts are designed, what sort of input data do we use, which model do we use. There's a whole lot of generative AI solutions. It's not just ChatGPT and OpenAI. There's a few others produced by other companies. And then there's a whole lot of funny little switches in the background you can tweak, which make massive differences to how they work. And very few people spend a lot of time talking about that. But if you wanted to use some Gen AI in your organization in healthcare, you've really got to care about everything. So in fact, compared to predictive AI, you've got to care about more things. Is this me being told off for going too long, Maja?
No, you got your 30-second call.
Oh, is that what it is? Okay, cool. Well, that's good. I've only got 2 more slides, I think. So, and look, just a reminder that, unless you're in a robotics space and, if you want to be scared, have a look at the Boston Dynamics website. They have some amazing robots. But at the moment, all of these models have to change human behavior. Healthcare is largely a human business, so we have to change humans. So if you haven't worked out how to connect this model to the human behavior and modify the behavior you want to modify it in the direction you want to modify it, the whole thing is an absolute waste of time. And please don't waste your time measuring how good the model is. Measure how good the model is when used by the humans that have to use it. And you often get dramatically opposing results. So, we had there's some studies with AI drafted replies, and even though the AI worked very quickly, what you found that it actually took longer to write the reply, created longer replies, and added compassion. But we don't know yet whether the longer replies are more efficient and create better healthcare outcomes. And so that's where it gets really interesting from a healthcare perspective. Some of the things that we might want to use AI for, I think are actually low-hanging fruit: identifying patients who are deteriorating before they deteriorate, identifying patients who are getting confused, measuring respiratory rate, the most sensitive indicator of a patient deteriorating. And guess which parameter is the least well done by nursing staff, medical staff, everybody. AI could do that for us. Operating theatre, count errors, we put 9 swabs in, we took 8 out. Oops, there's one there. AI can help with that sort of things. Did we do the timeout before the surgery? Are we operating on the right leg? These are things that we could have AI solutions help with today. But everybody's going on about writing briefs for you and writing emails to save you time. I really do feel that it's a bit sad that we're focusing on the wrong things sometimes. Anyway, this is my last slide, just to talk about, if you want to be successful with AI, make sure that whoever's building it or implementing it works with the clinical service people, the healthcare clinicians that provide healthcare. Get those people involved. User-centered design very much has a place in here, and you need to understand more about how human brains work, which is the cognitive science, because if you don't understand how the human works and you add an AI to it, you can actually make the human deteriorate. You can make the human brain work less effectively. That's one of the problems, because these models make people think that they are human or act like humans, but they don't. And they actually can change the way the humans using them think, which we already have evidence for. Be curious. Challenge assumptions, do some actual studies and measure things, and make sure you've got a really strong safety and quality mindset. It's not all about how usable something is. You've got to think about safety, quality. You've got to think about the legislation and compliance rules. You've got to think about your change management. This is generic stuff. Any IT project needs these 6 domains. There's nothing special about AI, so don't forget them. I won't do that last one. We can chat about it in the panel.
Thank you so much, John. And before I hand over to Professor Brian Abbey, if I could just say, pop your questions in the Q&A and we will address them at the end. Thanks very much. Over to you, Brian.
Thank you, Maja. So just a very brief background about me. So as Maja mentioned, my area of interest is in point of need biosensors and diagnostics for use in the community. I've also got one foot in the commercial world. I have a spin-out company that commercializes point-of-need tests, aiming to provide immediate or near-immediate results at the point of sampling. And a very good example that we're all familiar with of that is the COVID-19 rapid antigen test. So I've been fortunate in my career to have worked with some of the world's largest biotech companies, and from my collaborations with them, I can hold my hand up and say there are a raft of new point of need diagnostic tests which are going to come out on the market, which will enable healthcare providers or even individuals to administer tests and have control over their own healthcare. The big question mark is, where are the opportunities and potential benefits for these new technologies for remote communities? And I think that's a key point that I'm interested in discussing today. If I have a very forward-looking view, I've got just 2 slides I wanted to share just to give you an idea about some of the things we work on. So hopefully you can see this slide. Maja, is that coming up? Great. So this is just an example of where the technology is taking us. I'm not suggesting this is a potential solution for remote community health, but it's an example of what technology can do right now. So my group specialize in developing our readout for diagnostic tests as an optical readout, which means that if you have a particular biomarker associated with a given disease, our tests generate a colorimetric output. So we might have a test for heart disease where the sensor changes from yellow to red, or some kind of obvious readout along those lines. And we can miniaturize those tests. So we can make tests for specific biomarkers that are 200 times smaller than the width of the human hair. And these are things that are already in the research domain. So one question would be, where would this technology take us, in 7 years? Well, potentially it could take us to integrating these kinds of non-invasive tests into something like a toothbrush, where obviously you've got a ready-made saliva sampling kit right there that's in use in everyday life, where you can build in not just one test but potentially many tests into the bristles of the toothbrush. There have already been publications, not from my group but from others in the US, around optical detection of, say, biomarkers associated with cardiovascular disease, for example. So you can envisage the possibility of building in these types of detection tests into something like the bristles of a toothbrush. And what that might now allow you to do is actually provide the individual with an early warning system of when they're at higher risk of cardiovascular disease. This isn't science fiction. This is something which is in the realm of possibility of research right now. And the question in my mind is how technologies like this, or maybe utilizing similar platforms, could fundamentally benefit remote communities. For example, going from invasive testing to non-invasive testing, blood to saliva-based testing, and also how AI could be integrated to enable continuous monitoring of these types of tests. Other things on the horizon which are happening in the biosensor space is that we're commercializing at the moment a number of multiplex sensors, so sensors that can detect many biomarkers at once. So you have, instead of having one diagnostic test for one disease, you could have one diagnostic test for many diseases and be detecting multiple biomarkers associated with each one of those diseases for more accurate diagnosis. The huge change which has occurred in my field in the last 5 years is a massive reduction in the cost of diagnostics. So the kind of tests that we used to make for hundreds or even thousands of dollars 5 years ago, I'm not exaggerating, are now being made for a few dollars or even less. So the potential to actually take testing out of the clinic into the community has never been greater. Real-time monitoring is obviously a huge area of investment at the moment. By 2025, there are projected to be more than 20 billion sensors connected to the internet, including many sensors in your smartphone or watch. More sensors, obviously, than there are people on the planet. And so the question is, are there opportunities there as well to be able to collect real-time data that might be able to inform healthcare decisions in remote communities? I personally can see barriers to things like wearables being implemented in remote communities, but I think if designed in the correct way, there are opportunities as well. So taking advantage of these future opportunities in biosensors was the reason why I formed this a collaboration of 9 universities across Australia with a number of community controlled organisations. And what I've been doing this past 7 months is actually connecting with remote health organisations, clinics, community members, doctors, clinicians, and actually listening to what they have to say around the current state and the future of remote health in Australia. Just a small, very small selection of feedback. Some of the current challenges are obviously lack of local expertise to support on the in community healthcare. Often people don't want to get tested in the first place, particularly if they're asymptomatic. It can be hard to get people to go in and get tested, particularly if they know it might mean moving off country or having to go into a hospital or clinic. We've heard from many clinics, people just often don't want to know about the outcomes of testing sometimes, particularly if they know of the downstream consequences. There's just health can sometimes be a lower priority when you've got so many other things happening in your life. Technologies that work in metro communities often fail in remote settings. They're not robust enough. Some of the clinics we spoke to have multiple copies of the same instrument because they fail so often they need backups. The iStat blood analyzer, for example, is a great example of an instrument which is used in many clinics, but does often or sometimes break down and then can be expensive to repair and requires expertise to maintain. And many of the solutions, I think, that are being rolled out potentially lack sustainability. Researchers come with a new piece of tech that might work well, but when they leave the community, the testing stops and there's not enough resources in place then to keep the program going. I think the argument to government to adopt new technologies has to be made on the basis of healthcare economics, and there has to be strong data to support that. And so it's important, I think, that there is a plan to ensure sustainability of technologies in communities. Whilst the feedback from the remote community partners that we interviewed, actually, even though every community was slightly different, there were the same issues that kept coming up, and often people would agree when we raised some of these issues to them. But when we interviewed the academics and researchers, there was quite a different situation. We actually found that the solution to these problems varied depending on which group you talk to, and these were groups who were already working with remote communities. The range of solutions varied between things like focusing on telehealth, non-invasive testing, looking at whether people could self-administer and do at-home testing. So there are groups working in all of these areas. One area of consensus, though, was how critical it is to invest in the future of community-based point of need testing, and that the current reliance for some samples to be sent to hospitals. So is that my time warning? For example, in Northern Territory, sending samples to Darwin or Alice Springs, which can take days, or even to Perth, can mean that samples aren't viable. So there is a consensus need, I think, to improve community-based point of need testing, and I'm quite certain that if you want the on-the-spot results, that will involve AI as well. So I think, given I'm out of time, I might hand over. Just my last point I would like to make, though, is that we know from the data and the evidence it is more expensive to get healthcare support in remote communities than it is in metro areas. Australia's population is increasing, but it's increasing disproportionately towards urban areas. So my concern, based on the interviews and the feedback that we've had with healthcare professionals, is that if we don't future-proof our healthcare system, we could potentially fall off a cliff with diagnostic testing in remote communities. So I think that's this conversation today is extremely timely, and I'm very grateful to Maja for organising it. So thank you.
Thanks, Brian. And I will hand over to Professor Sandeep Reddy for the workforce implications and beyond. Thank you.
I have a couple of slides that I would like to share. They're quite a few slides, so should be able to finish that within the 10 minutes, Maya. But before I go ahead, I would like to pay my respects to the traditional custodians of the lands upon which we gather. So something that is often not discussed but is very relevant to today is the workforce issue. If you look at the slide that I'm sharing, you will see on one hand, you will see the time it takes to train a physician. This is indicative, and depending upon the jurisdiction, depending upon the curriculum, it could vary, but on average, you're looking at about 11 to 14 years of training before a physician is able to function independently. And again, there's the continuing professional development. On the other hand, you have the artificial intelligence or medical technology, where in terms of being able to process data, but also being able to function and scale, it's much more in terms of time and also in terms of the cost. It's very, very contained. And if you look at the news headlines that is coming across from across Australia and from across the world in terms of how healthcare systems are in crisis, hospitals are facing severe budget cuts and the implications of workforce, it does make you wonder in terms of the utility of AI. So let me explain that or build that case further. So it may surprise you. That 67% of the world already are using AI, and you can potentially challenge that. But if you think about the number of people who have access to internet, that's about 67%. And when you use internet in some form or another, you're using AI, whether you're doing a search or using Google Maps, or you're using your emails or your banking systems, AI is already being used. So somebody to come to you and say, is there a question of using AI? They're really living in a fantasy world because we're already using AI. So it's not a matter of whether we are using AI or to use AI. It's about where you're going to use AI or how extensive AI is going to be prevalent in the work domain that you operate. So in terms of the medicine itself, AI can be used in prognosis, diagnosis, triaging, and screening, but it's also evident on the slide the versatility of AI in being able to be used in different areas. However, AI does come with challenges, implementation, and there are numerous challenges, including the potential of introducing biases in terms of being able to discriminate against vulnerable population. Here in Australia, it would be the First Nations people or people with other kind of disadvantages. And there's also the issue of the lack of explainability, especially with deep learning. And that's some area that I'm very interested in, how we can offer solutions in that area. And obviously, there are emerging solutions, something we call as explainable AI, but there still remains a problem and challenge with deep learning algorithms in being unable to understand the decision making. It's quite opaque, and especially nowadays with generative AI, there's a requirement of high or significant computing infrastructure. If you're developing your own large language model, that becomes all the more acute, and there's already a shortage of GPUs. There's a high demand for that. And then when you think about AI adoption in healthcare and why it is very, very poor, it's because the lack of integration or the very minimal integration of AI into clinical workflows. I'll be talking about that in the next few slides. And there's also lack of understanding of the utility of AI or way AI can be used. And that's something also that is posing challenge, especially in terms of AI application in healthcare. Further to that, there are significant medical legal concerns. And one of the prominent aspect is that there isn't still really specific laws that can considered in terms of medical legal implications of AI, especially when AI goes awry, things go awry, and there's patient adverse events that can affect patients. So in consideration of that, way back in 2019, myself and my co-authors, we published a paper in the Journal of American Medical Informatics. So far, we have received over 540 citations, and we introduced the concept of governance. I don't want to take too much time, do want to refer you to the paper. What it does cover is all certain areas where it really addresses all those previously mentioned problems. And the four main key areas is fairness, where we talk about setting up data governance panels in terms of identifying suitable AI, but also while developing AI algorithms. And prior to us commencing this webinar, we talked about procurement, and that's also where data governance panels or clinical governance panels can be involved in identifying suitable AI products. And in terms of transparency, identifying those AI models that are self-explanatory or inherently interpretable, but if not, using explainable AI frameworks. In terms of trustworthiness, educating the workforce, but also educating the community about AI, but also dispelling any misconceptions about AI. Accountability, setting up medical, legal, or accountability frameworks, especially when things go wrong with AI. The last slide that I want to end with is how do we consider or how do we enable AI integration into clinical workflows? This is a major problem. If you look at the AI adoption rates in healthcare, it's very, very poor compared to other sectors. And that a large part of it is to do with the lack of integration into existing workflows, or when AI is being adopted, it actually adds more work to the clinician. So that's something that we have to focus more on. And this is a potential pathway on how to consider AI and also integrate AI. So the main key message is to ensure that when we integrate AI, it doesn't add work to the clinician, but also optimizes the workflow. So with that, I would like to end my presentation.
Fabulous. Thank you so much, Sandeep. So what I would like to do now is I will reopen the chat and invite anybody to ask a question of any of the panel members. I know there are a couple of questions in the chat or in the Q&A already. And I see, John, that you've answered the first one. So perhaps if we start with the next one from Mary Claire. And I assume by QA you mean quality assurance, Mary Claire? So is QA built into the point of need testing devices to comply with accreditation processes? So Brian, this is for you.
Yes, depending on the. So I'm commercializing a Class 2 IVD. So the regulatory and accreditation process is the same as any other medical device. So you have to, your clinical evidence generation pathways, the quality assurance, the quality management systems all have to be developed in the same way. The one grey area, actually, this is where I'm interested to hear from John and Sandeep, is with our US partners, we're actually developing an AI add-on, you can say, to our platform because they're interested in having a digital pathology aspect to our diagnostic test. But the regulatory pathway for the AI component is much less clear, to me at least, than the platform technology. So I think in the context of this discussion, and I've talked to other startup companies and other AI companies as well, I think the legislation is playing catch up with the AI field in some way. So I'm interested potentially in hearing maybe from John and Sandeep on that.
John and Sandeep?
Yeah, look, this one might be better for Sandeep. I mean, the regulatory environment around AI models, both predictive and generative, and in fact, I think more broadly around digital solutions in general, is very fluid at the moment, let's say. They're still trying to work out how we can manage this. One of the tough things, I think, for AI developers in particular is that the technology is moving at such a fast pace. By the time we get enough evidence, and like all of the regulatory frameworks for, say, drugs and procedures and physical devices and the sorts of things you're building, Brian, based on clinical proof of capability, how do you cope with that when by the time you've generated the clinical proof, the system's 4 versions old? And so we're all trying to grapple with how we can keep up with the rate of change of these models. So what I can say is there's an Australian Association of AI in Healthcare that's looking at this. The Australian Digital Health Agency is looking at this. That at least it has created a nice outcome in that all the jurisdictions of Australia, at least, recognise this and want to do it once. In the old days, we'd all wanted to go our separate ways, but now everybody's saying we can't do that. So at least let's do it in a uniform way, which is really positive.
Thank you, Sandeep.
Yeah, I wanted to add something. For me, FDA, the Food and Drug Administration, which is our equivalent to the Therapeutics Good Administration, seems world leading in that aspect. They have specialized streamlined pathways. In fact, it's much more than one pathway. There are a couple of options in terms of where your product is, and focusing on AI. Here in TGA, the focus is on more on the clinical outcomes and the risk, the category of risk where the AI application falls on. But I like the way FDA has structured its, in terms of its approval of software as a medical device, focusing on AI, and also being able to, in terms of preempt any potential changes to the algorithm, instead of adding more burden to the vendors or the developers, being able to take that into account and have a much more streamlined pathway. But as John and Brian mentioned, it's a moving feast. It's really trying to catch up with what's happening with AI. For me, as both as an academic and as an entrepreneur, the issue is not so much as to the framework or the requirement of such kind of regulatory processes, but the time it takes to get that approval. And that's where it is a challenge for, especially for small and medium enterprises, if they want to go through the regulatory process, the time and cost, it's very forbidding. So that's something I think the authorities, if anybody here is involved in that area in terms of policy, that they should look into it.
Thank you, Sandeep. And Mary Claire, I'll get to you in a moment. There's a few questions in the chat we need to get to as well. This is from Ziggy in terms of the most urgent gaps you see. So we've established that AI can help to bridge a knowledge gap in medicine, in particular where there's lack of expertise from a workforce perspective, in particular in remote areas. Is knowledge all that's required to make a difference, or is there more that needs to be done in order to convert that knowledge into improved outcomes? John, first in best dressed.
Well, I just wanted to say I don't know that I agree with the first statement. I don't think we've established at all that AI can help with bridging the knowledge gap. You know, a lot of studies looking at generative AI, which I assume is what you're talking about here, because the predictive AI doesn't really fit that use, has shown that the models have a lot to be desired, and the way you ask the question can result in dramatically incorrect advice. And so I wouldn't use a Gen AI solution, for instance, for serious medical advice anywhere at this point in time. I think that would be very risky. But I think we'd like it to help. And so, yes, I don't know that knowledge is all that is required, because you know, there's data, there's knowledge, there's wisdom, and the wisdom bit's always going to be missing if you just, you know, implant knowledge into the equation. So I think we've still got a way to go. I hope I'm not being too negative and a Luddite in saying that, but I really don't think that's all we need to address the problems.
Thanks, John. Yeah, Brian?
Just very briefly, yeah, I'd agree with that. And I'd just emphasize the need. I think it's so important that the people who are developing the technologies, so like myself, are working hand in glove with the experts in AI, because what we're looking at, I don't think any one element is the solution. I think we need to think about the whole journey from sampling to diagnosis, if you're working in the diagnostic area, and that involves a integration of all of these different fields together. Because I think there's no, at least from my experience, no off-the-shelf solution when you're doing the technology development. So yeah, it's a multidisciplinary problem from my perspective.
Absolutely. Thanks, Brian. And you're amongst friends here in this innovation community of practice. That's absolutely key, is that diverse transdisciplinary conversations. Sandeep, is there anything you wanted to add to that one?
Not
No.
to that one. There was a question here. I don't know if it is in your order, Maya. It's about a comparison of a pigeon doing what in terms of identifying things. I think what we are seeing in terms of the evolution of AI is the most mature part is where AI can analyze and interpret medical images. That's primarily because of convolutional neural networks. They are really great in being able to do hierarchical and analyze pixel-based images. And we also seen randomized controlled trials and published studies where they're shown AI algorithms that have utilized convolutional neural networks, meeting or matching the performance of radiologists. So I think we have moved past that, and now there's emergence of large vision models. While it's very early to assess their performance compared to the previous generation of medical imaging models, for sure we have achieved a great degree of maturity in terms of analyzing medical images. Other areas, yeah, it's still questionable, and as John mentioned, using whether it's discriminative AI or generative AI in terms of risky clinical situations, I don't think we are ready there.
Thank you. So this question, very interesting. How to ensure that smarter systems don't result in dumber doctors?
I mean, I'm happy to butt in first. I think it's a particular risk, actually. Like, people talk about the predictive AI solutions replacing radiologists, but I actually think Gen AI is perhaps a more pervasive risk. And I actually don't know that we're going to stop it to a degree. I think it probably is going to happen to a degree because humans are essentially lazy. And if they see something that'll do the job quicker, easier, and, you know, most of the time it does a pretty good job, it's a very powerful force to work against. Convenience is incredibly powerful. And look at the way we give away our privacy and all of our information about our lives to a company for nothing, so that we can, you know, send messages to our family on Facebook or whatever. But I do feel that it does provide an opportunity for us to do something about education. Education about digital systems, how AI works, but also education about ourselves. Using our models illustrates some of the flaws in human behavior and human cognition, and I think that we will learn a lot about ourselves through the use of AI, which probably isn't a view that a lot of people talk about, but I think that, you know, we might be dumber at some things, but we might get smarter at other things. So that's my hope anyway. Call me an optimist.
Thanks, John. Brian?
Just briefly on that, this is from just conversations with friends, I guess. I am friends with a few pathologists I work with closely. So there have been, I think, studies performed, and John and Sandeep maybe know better about this, where they've shown that when AI has been introduced, the pathologists, and this is in the digital pathology context, have had an over-reliance on the AI outcome, which has made their diagnosis subjective compared to what they would have come to if there hadn't been the AI-assisted diagnosis. So I think there is that concern about the dumber doctors. I'm not sure I'd phrase that around my friends, but there is some truth to that. I think I do think, though, knowing how for different disease settings there are different frameworks for how you reach a diagnostic outcome. I think that there is potentially a halfway house with AI and improving diagnostic accuracy, in that you still have the human, the expert, you know, involved in making sure that we're maintaining that very high standard of care, but that the AI is maybe doing something a level below providing a preemptive diagnostic outcome, but is actually enabling the assisting the doctor or pathologist to apply their expertise and their knowledge to come to a diagnosis. So I think maybe we're in that phase where we want to proceed kind of in baby steps before kind of making those big leaps. But that's just my thoughts.
Thanks, Brian. John?
But I've just got something I just want to share briefly as evidence behind this. It's not even so much making them dumber. What we already know from the limited implementations available today is that it changes our behavior. Is it good or bad? So if you look at this slide I've got up on screen here, I'll just add, sorry, there's an overlay. Yeah, here we go. So if you look over here, so this is a tool that basically drafts responses to patients on a patient portal. So in America, they have lots of patient portals where patients can communicate directly with their clinicians. We don't have many in Australia. But of course, the clinicians are overwhelmed by these messages. So they want to use a ChatGPT type solution to write the responses. So the blue bar reflects how many times without the AI involved at all, the doctor would recommend an action, like get into hospital, see somebody, do something about this message you've sent me. The next bar, which isn't even visible here, is what the draft large language model did. It almost never recommended immediate action. But what's really interesting is the green bar, because when the doctors were presented with that draft, they then didn't recommend action nearly as frequently as they did without the draft. So there's clear evidence that, and you know, like this is, nobody would think of this as a particularly invasive clinical decision support tool, would they? Like it's just writing messages back to people who are sending text messages into a portal. But that is a fundamental change of behaviour that you know, in a simplest, very easy, short-term study has clearly made a difference to the way doctors think. Now, is it better? Is it smarter? Because, you know, what you also see here is a lot more contingency. So that's where the message says, well, you might have this, you might have that, might have the other. Doctors are not like that. We just, no, it's going to be this. This is the advice I'm going to give you. So maybe because of the caveats, it's actually safer. We don't know, but you've got to study it. And that's the point I'm making. It's definitely changed behaviour. Whether that's good or bad, whether the doctors are dumber or smarter, I can't judge that. But we do know that these things can have a massive impact, and we should always be questioning whether the impact is good or bad.
Thanks, John. Now, I'm very mindful we are not going to get through all of the questions. I will go through another couple. But can I just ask the panel if you're happy to respond to those questions either in writing or if you can flick them to me, and I'll make them available on the digital professions platform for those members. So if you have written a question and we don't get to it, please feel free to message me. I will give contact details shortly, and we can make sure that we get those questions answered. I am very mindful that one of the reasons that we came together today was because of the workforce shortage in regional and remote locations. So I guess if I can just bring us back to that, are there any sort of final statements in relation to how we can support the healthcare needs of regional and remote Australians using this technology? And then we'll do some summing up. I'll stop the recording, and again, we'll try and get back to those questions out of session. So Sandeep, did you want to go first? You look like you're ready to.
No, happy for John or Brad to go first, but I did want to raise the possibility of AI being, because I was in the NT for 6 years, both in Darwin and Alice Springs, and prior to that in New Zealand, I was in a very remote location in the west coast of South Island. And my medical training in India involved a lot of work in remote locations too. So I do have that firsthand experience of living in remote locations and being a clinical provider, but also being a recipient of healthcare. So one thing I really think there is, I feel very optimistic at least, is where AI can play a big role is in triaging and screening and early detection of diseases. So we know in the Northern Territory, in remote communities, we have a high prevalence of diabetes type 2, and that leads on to chronic kidney disease, and that leads to end-stage kidney disease. And we know the cost burden and the health burden on communities because of that. So from that point of view, I think there's definitely a role for AI as we speak, and there is enough maturity in AI applications to do preliminary triaging and screening. Beyond that, it's questionable. We haven't seen trials, but for sure, there's ample evidence for AI being able to detect diabetes and other chronic conditions, or even cancer and so forth.
Thank you, Sandy. Brian and John, I note that you're busily responding to questions in the chat as well.
Well, I mean, the one I just gave is probably partly an answer to this question, and that's why I wanted to type it in there. But look, healthcare is quite conservative. We all know that, and it's generally for good reason. Like, we wouldn't introduce a new drug therapy or a new procedure without proving that it's safe and appropriate and of high quality, etc., and didn't have bias. So I don't think AI is any different. But on the other hand, I do feel that if we choose to, we can already use AI to make a massive difference to efficiency of the not the procedural, but the administrative side of healthcare. So we could do a better job of scheduling. We could do a better job of ensuring that the services we provide in which area are provided at the right time, in the right place, in a way that is culturally appropriate for our citizens. And so there are definitely low-hanging fruit there, but we have to get people to pay attention to that and consider that important, and not, worry about less important things. The other area, despite my skepticism, I do actually think there's some interesting developments in what we call ambient AI. So these are generative AI tools that listen to a conversation between a clinician and the patient, and then can write efficient summaries of that care. And some of the implementations I've seen, not all of them, are actually pretty sensible and are explainable and safe, and seem to do better jobs of addressing the dumbing down of doctors and the replacing issues. And I'd like to think that we will be trialling some of those in Northern Territory sooner rather than later, possibly even in Mary Claire's place, as part of our EMR. And it'll be interesting to see if that makes an actual difference. It could make things worse, I don't know. But I think we'll be trialling some of those up here because of the disadvantage we face up here. It's a great place to try and make a difference.
Brian, did you want to comment on your upcoming visit?
It's more to I'm visiting Alice Springs and the Yondamu to get some on the ground feedback as well. I mean, a lot of what we've been doing the last 7 months is scoping need and making sure that we're testing our assumptions around where we need to apply technology, because I find that there's the research literature and what you would call what I call the grey literature, which is, I think that what our interviews and discussions and on the ground feedback has been is not always captured in what actually makes it into the published literature. So I find that these in-person visits are incredibly useful. I might, if I can, just really briefly comment about what I've seen in terms of AI and healthcare as a non-AI person who's very interested in AI and healthcare. I think that there's a myth, a little bit of a myth that, for example, the pathology community, for example, is a bit resistant to AI because it has potential implications for workforce and things like that. But what I actually seen, at least from my immediate circle, is the opposite. I think that there is a huge and a growing backlog of samples. We're getting better screening, we're getting earlier detection, but that creates a need to actually get through samples much more efficiently, and it's becoming I think quite urgent. So there is, I think, actually a lot of receptiveness at least in the community that I work with, to actually see these tools come through, with all the caveats we've talked about in terms of needing to meet the verification standards. And also, I can tell you from what I see directly, multinationals are pouring resources into AI at the moment. And so the only thing I am absolutely sure about is that AI and digital health is coming, whatever the time frame is for that. It is absolutely going to be implemented at some point in the future. And like I said, my hope is that it is implemented in a way that is meets the highest standards and actually is sensitive to all the issues that we've raised today. So rightly or wrongly, I think it's inevitable, to be honest with you.
Thank you so much, Brian. Look, I'm not mindful of the time, so I just wanted to let everyone on the call know that there are a number of options of where to from here. So if you are not already a member of the Data and Digital Professions platform, you do have a .gov.au email address, you are welcome to join. There is the link. Also, the Australasian College of Health Service Managers are supportive of continuing this kind of conversation, this kind of theme in a future Congress, not this year perhaps, but in the future. So keep an eye out for that. If you are a healthcare professional, that might be a place to come and play. Brian Abbey is in an exploratory phase of a Centre of Excellence, and so if you are keen to learn more in terms of the biosensing and what can happen in remote locations, please feel free to contact him. I will leave the rest as said, and I will flick to the next slide, which is our contact details if you would like to contact us. We thank you so much for your time today. We hope this session has been useful, somewhat ambitious. It's a massive subject, and we absolutely need to be working together to continue this conversation. So thank you all very much for your time.